Dear participant, welcome. I am Mariangela Pellegrini. I work for the European Reference Network on Rare Hematological Diseases, the ERN-EuroBloodNet, and it's my great pleasure to welcome you on behalf of the whole ERN to this session of the Thursday webinar. So as you may know, this Thursday webinar are educational activity for promoting the interest on very innovative topics with the aim of disseminate among health professionals the cutting-edge advances in the field of rare hematological disease. With this aim, today we are going to assist to a lecture on Daratumumab-Based treatment for immunoglobulin light chain amyloidosis. And so, dear audience, please welcome with me the speaker of today's session, so the Professor Arnauld Jaccard, who is head of hematology department at University Hospital of Limoges in France, and professor of hematology at Limoges University of Medicine. Please, Professor Jaccard, the floor is yours. Thank you very much.
Thank you for your introduction, and good afternoon to all, and particularly to Gianpaolo Merlini and Nathalie Möllmann. I would talk about Daratumumab-based treatment for immunoglobulin light chain amyloidosis. So I hope we will have a discussion after the talk. So here are my disclosures. So in L amyloidosis, there is always a monoclonal B cell, most of the time a plasma cell, usually with an IgG or free light chain only gammopathy. And in less than 10% of cases, the monoclonal gammopathy is an IgM with mainly lymphoproliferative disorder in the bone marrow. But the B cell proliferation should be carefully studied before treatment. This Mayo Clinic study showed that in 1/4 of patients with an IgM amyloidosis, there is a pure plasma cell neoplasm in the bone marrow, with a majority of patients harboring a translocation 11-14. In 60% of cases, the B-cell dyscrasia is a MGUS, and in 40% a smoldering multiple myeloma with more than 10% plasma cell in the bone marrow, but usually no CRAB criteria. Evolution to a symptomatic multiple myeloma is very rare, only 6 cases among more than 1,500 in this Mayo Clinic series. So L amyloidosis is really a MGCS, a monoclonal gammopathy of clinical significance. And monoclonal plasma cells are stressed by the abnormal light chains and are very sensitive to treatment, particularly dexamethasone and proteasome inhibitors. And prognosis is clearly depending on cardiac involvement, and cardiac biomarker as the basis of this staging. The classic Mayo staging, stage 1 with normal NT-proBNP and troponin, stage 2 with only one elevated, and stage 3 with both elevated. In the European staging, stage 3 is split between 3A with NT-proBNP below 8,500 and 3B above. And in the last Mayo staging, DFLC, the difference between the monoclonal light chain serum value and the polyclonal is added, and as you see, patients with a high DFLC have a worse prognosis. But the best way to discriminate the more severe patient is a 3B stage with a 4 to 5 months median survival. Prognostic is clearly dependent on hematologic response measured on serum free light chain. Patients with a complete response have the best prognosis, and you should obtain at least a very good partial response with a DFLC below 40 milligrams. For complete response, it's probably better to use the normalization of the monoclonal free light chain level rather than the ratio, like in the Andromeda study. published in the New England Journal of Medicine in July, or the low DFLC response, like in this publication from the London team, where it is a better predictor of survival than the classic criteria. And in the patient in CR, it's better to have a negative MRD with better organ responses and a better PFS, as shown in this Italian study. So the treatment of AL amyloidosis is based on the fact that if the serum level of the amyloidogenic protein decreases, involved organs are getting better, most of the time slowly with different speed in different organs. It can be rapid in the liver, but usually really slow for kidney or heart, and it takes 1 year of CR to see an amelioration of a macroglossia. And you always have to remember that chemotherapy is not directly active on amyloidosis deposits. And a key point in this disease is that the more severe the disease is, the faster you must obtain a response. Here is a survival curve of 130 patients in our database who did not reach a response at 3 months, depending on myostaging. In stage 1, you have the time to give a salvage treatment to the patient, not too much time in stage 2, and no time at all in stage 3. And in this published studies, in this study published in 2018, in the more severe patients, the stage 3B, the patients who reach at least a VGPR at 1 month have a much better survival. It means that you must closely monitor the hematologic response to tranche treatment, sometimes before 1 month, for the more severe patients. Here's the evolution of treatment in AL amyloidosis from a recent paper from Ray Comenzo in Boston. With MP, the response rate was only 30% and the survival 1.5 years. It was 65% with high-dose treatment or MDEX, 80% with bortezomib containing regimen, and 92% with the combination of VCD plus daratumumab that is used in the Andromeda trial. Since the publication in the New England Journal of Medicine of our study comparing MDEX and high-dose treatment showing a better survival, 56 versus 22 months, we do not propose stem cell transplantation in first line in amyloidosis. Of note, with a longer follow-up, more than 10 years, there is no advantage for autologous stem cell transplantation, even in the landmark analysis, with only patients who receive that allotted treatment and surviving at 6 months. And in this debate at the COSTEM 21 last October, that is online, Gianpaolo Merlini defended the no place for autologous stem cell transplantation in amyloidosis. His conclusions are that the vast majority of patients are not eligible for high-dose melphalan and that the availability of new and powerful drugs reduce the indication for transplantation. I don't really agree with the point 1 and 2. For patients with suboptimal response to first-line treatment or with a contraindication to bortezomib, new drugs are probably more effective. At the last ASH meeting, a retrospective study from the MD Anderson Center found in 33 patients who were refractory to an induction treatment before stem cell transplantation, a 74% of overall response rate after high-dose treatment, but only 29 of VGPR or better. And that's between 17 and 80% with new treatment in this disease, with patients with more lines of previous treatment. I think the good indications are patients with an overt multiple myeloma and a mild amyloidosis, and patients with an IgM who are not in good response. So the Andromeda study was published in the New England Journal of Medicine in July and presented in several meetings. Here is the last presentation by Ray Comenzo in the last ASH meeting in December. So daratumumab is one of the new treatments that make, in my, I think, autologous stem cell transplantation obsolete. Andromeda is a multicentric phase 3 trial comparing in almost 40 patients the most used chemotherapy regimen, VCD, bortezomib, cyclophosphamide, and dexamethasone, given for 6 cycles to the same VCD plus sub-Q daratumumab within the DARA arm, 1.5 years of monthly DARA after the first 6 months. First-line patients were included, excluding 3B patients. Patients were stratified on cardiac stages and creatinine clearance. Primary endpoint was complete hematologic response, organ response rate, time to hematologic response survival, and safety, and what was called MOD PFS, a composite endpoint defined as end-stage organ disease, hematologic progression, or death. The median age was 63, and a third of the patients were in stage 3A. At the last cut-off in May 21, the median duration of treatment was 21.3 months for the DARA arm and 5.3 months for the VCD arm. The majority of patients in the DARA arm are received DARA monotherapy. Hematologic CR was defined as normalization of FLC level and negative serum and urine immunofixation. It was the first objective, complete response, and the study was clearly positive, with an unprecedented rate of 60% of patients reaching CR in the DARA arm versus 19% in the VCD arm. 92% of patients had a response in the DARA arm versus 77% in the VCD arm. It was 79 and 50 for VGPR, which was reached in 17 days in the DARA arm and 25 days in the VCD arm. Of note, it was in all pre-specified subgroups, particularly patients with stage 3 cardiac stage and patients with a T1114. And this excellent rates of hematologic response translate in a doubling of organ response, 53 versus 24 at 18 months for the heart, and 58 versus 26 for the renal response. Even with no stage 3B patient, these survival curves are very impressive. There is, at this time, no statistical difference, but half of the patients in the VCD arm receive a second-line treatment that was daratumumab in 60% of patients. So based on these findings, DVCD was approved for newly diagnosed AL amyloidosis patients in January 2001 in the US and June 2021 in Europe. For the very severe stage 3B patients, studies ongoing in Europe. It's a phase 2 multicentric open-label study planning to enroll 40 newly diagnosed patients with stage 3B AL amyloidosis from 5 sites in Greece, Netherlands, Italy, and France. Eligible patients should have high sensitivity troponin, more than 54 picogram per milliliter, and NT-proBNP more than 8,500. If no VGPR is reached by cycle 4, patients could receive weekly bortezomib and low-dose dexamethasone. In my, I think that it's too late to switch treatment in case of non-response for stage 3B patients, but it was writing like this in the protocol. We have a preliminary analysis of 17 patients that were published at the last ASH meeting. Median NT-proBNP for this patient were really high, more than 13,000, troponin 119, and DFLC very high, 553. And the patient received a median number or 13 DARA injections. The follow-up was 4.4 months. And the response rate was really good for patients with 3B stage. It was 70% for overall response and 52% VGPR or more. And the response were really rapid with 1 week to reach a response. And the overall survival is not so bad for patients with 3B stage, with 50% of patients surviving more than 12 months. But the more severe patients have not been included in this study. So we have to wait the complete result to know if daratumumab monotherapy is really a good treatment in patients with 3B. For patients in relapsed refractory setting, 2 prospective phase 2 studies from France and USA were published in the same issue of Blood, with a compilation of 168 patients treated in Germany, and it was accompanied by an editorial from Angela Dispensieri. In our AMIDARA study, we include 40 patients in relapse of refractory in France and Italy, and we gave them IV daratumumab plus low-dose dexamethasone for 6 months with the usual schedule. We excluded patients with an overt myeloma, 3B patients, and patients with a low blood pressure. In the Andromeda study, daratumumab was given sub-Q. Here are the characteristics of patient, a median of 69 years of age, 3 previous lines of treatment, 95 patients treated with bortezomib and more than 60% with ERT and or renal involvement. We obtained an excellent 70% of response rate with 57.5% of VGPR or better for the best response. Of note, the response were very rapid with 50% of patients in response after only 1 injection. The 22 responder patients had a decrease in DFLC of 63% after only 1 injection. But patients who did not reach a response after 4 injections never respond. So see, if you have not a response at 1 month with DARA monotherapy, you have to add a drug or to change the treatment. In the Boston study, compared to AMIDARA, 22 patients were included with 2 prior therapies. The majority have received an autologous stem cell transplantation before, so they are good risk patients. They received 2 years of DARA. It was 6 months in our study. The median DFLC was twice lower, and they obtained a better response rate of 90% in this study. In AMIDARA, with a median follow-up of 14.5 months, half of the 22 responder patients have been retreated, but only 1 among the 9 with a DFLC below 10 milligrams per liter at the end of treatment. Here, an example of patient with cardiac, renal, liver, and bone AL amyloidosis who did not respond to VCD, had a rapid relapse after VRD, and is in continuous CR at 4 years after 6 months of daratumumab. In the third paper published in the same issue of Blood, 168 patients received DARA, 106 in monotherapy. VGPR was less likely to be reached among patients with high DFLC, more than 180 milligrams per liter. And hematologic PFS and OS were adversely affected by high DFLC and 1Q gain. In addition, higher level of albuminuria also adversely affected hematologic PFS, probably due to a substantial loss of daratumumab through renal excretion. And in a recent study by the same team, 44 patients were treated with DRD, This study confirmed that IDFLC and 1Q gain, but not T1114, were adverse prognostic factors. And isatuximab, the other anti-CD38 antibody, seems to have the same efficacy than daratumumab, with almost 80% of response in this study reported at the ASH meeting in 2020. Our trial in France and Australia combining isatuximab and pomalidomide should begin this month. So, daratumumab is certainly an important drug in AL amyloidosis treatment, first line or in the relapse refractory setting with high rates of rapid response and no serious toxicity. Many unsolved questions remain. Should all patients receive daratumumab in first line? We think that there is a role for more simple and cheaper treatment in very good risk patients if there is a very careful and rapid evaluation of hematologic response to add DARA after 2 months, for example, if the patient had not reached CR. What is the best drug to combine with DARA? What should be the duration of treatment in myeloma? The Cassiopeia trial showed that there is no gain with DARA maintenance if DARA has been used in induction. For very good responder, we obtain a very long PFS in the AMIDARA trial. And status cascades has shown in a small study, including 25 patients not in CR after a bortezomib-based therapy, that with 4 weekly infusion of DARA, the response was enhanced in 1/3 of patients with a sustained CR at 2 years in 100% of patients in CR. So we don't really know what is the best treatment duration. And we are waiting for the complete result of the phase 3 study using DARA. Using DARA for stage 3B patients, the first result of the 17 patients are really encouraging. T1114 is not associated with a lower response rate with DARA, but certainly with VCD. It is present in 50% of amyloidosis patients and up to 70% for free light chain only patients. And it's not daratumumab, but I think it's important to know that venetoclax is a very good drug for this patient with an 88% response rate in this small study for the Mayo Clinic team. And we can obtain very rapid response as shown in these 2 cases of patients treated in Limoges. And in this retrospective international study, the 27 patients with a T1114 had almost an 80% response rate with 41% of CR. So daratumumab is really a good drug. Venetoclax is really a good drug. So we have new way to treat patients with AL amyloidosis. So thanks to all members of the French Network for AL amyloidosis, to Janssen for providing the drug and in part funding the AMIDARA trial. And thanks you for your attention, and I will be happy to discuss about this topic. Thank you.
Thank you very much, Professor Jaccard. So I said before, now there is a unique possibility to directly ask to the expert of the cutting edge topic some questions. So you can both write in the chat, or you can also unmute yourself and raise directly the question. So
there are a lot of questions remaining, particularly the duration of treatment, and do we have to give daratumumab to all patients with amyloidosis? That's really not completely easy to respond. So Gianpaolo, you have a question?
Yes. Yes, I have a question. First of all, can you hear me?
Yeah,
Yes.
yeah.
Great. Well, congratulations, Arnauld. A great presentation indeed. Very well done as usual. I agree with you that venetoclax is an important resource, but there was some concern about safety about this drug. And do you think that is already mature to be proposed in amyloidosis? I will use it mostly in relapse patients, of course, or in patients with 11-14 that do not respond well to DARA. But some colleagues, I agree with you that is a really important drug, but when I said so at some meetings, some colleagues raised concern about the safety of this drug. What is your feeling about this?
We have used now in several patients. When you give venetoclax alone, it's really, really well tolerated, and I have not seen any side effects more than some digestive problem, and I have not observed any infection. You know, in myeloma, the problem was infection, but in amyloidosis, I have not seen any problem. It's very well tolerated. It's oral, and I have been very impressed by the response of some patients. The one I have shown, he was in complete response after 4 days. He come back to see me after 4 days, and I checked the free light chain. It was completely normal. And I stopped after 7 months, and now it's 1.5 years after stopping the drug, and he's still in complete response. So it's really, I think, a very interesting drug, and I hope we can use it more in patients with T1114.
Yeah, I fully agree with you. And will you think that it may be used particularly in patients with 3B?
Yeah, I have treated some 3B patients who were not in response after VCD DARA.
Yeah.
I gave them 2 patients venetoclax, and they reached CR. So I think it could be used. There is no, I think, cardiac toxicity with this drug. Now we only use in relapsing or refractory patient, but I think a first-line protocol with the combination, for example, Daratumumab and venetoclax, should be very interesting.
Yes, indeed, particularly in patients with advanced cardiac involvement.
Yeah.
Where we don't have time, as you said very well, to wait for response. So it is patient that will go with DARA plus venetoclax indeed.
You can use it in Italy, venetoclax?
Well, no, but as usual, I mean, it's not approved for amyloidosis, but we can use it for myeloma. So we can use some strategy to get it.
Okay, it's like in France, so.
So we all struggle for this, but again, congratulations. As you said, Arnauld, there are many questions open in amyloidosis, but what is really clear is that DARA has really improved the care of these patients.
Sure.
If we have enough courage, I think that we should add also venetoclax to get a further improvement in this disease. I think that it is way we can rescue most of the patients and give them a very long survival. Okay, thank you very much for your presentation.
Thank you. Natalie, you have a question?
Yes, I have a lot of questions, but I think that I will not. I had just a problem to raise my hand, and so I didn't react. directly. But as you said, today we still do not have this answer, how long have we to treat our patient. But I think that in first line, we have a phase 3 study, so probably we have to follow this scheduled. But in the relapse setting, with daratumumab, sometimes it's difficult to decide if we will start with daratumumab in monotherapy, in combination, and how long we will treat our patient, because we have some studies, but studies, your study, it was during 6 months, other studies during 2 years, and some in monotherapy, others combination. I don't know, what is your attitude in patient relapsing in second line of treatment? So you will start with daratumumab in monotherapy, and then at a second drug, if you do not have a good response after for injection, or you will start?
Yeah, we often do a strategy with only maybe daratumumab alone, and look at the response after 1 month or 2 months, and add bortezomib, for example, if there is not a response. It depends on the severity of the relapse. Patient with a severe cardiac disease, often we give a combination, bortezomib, for example. It depends. Patient with a lot of plasma cells in the bone marrow, maybe we will give daratumumab plus lenalidomide. You know, like in myeloma, it depends really on plasma cells, on the severity of the disease, of what the patient has received before. Mm-hmm. We have shown that when the bortezomib containing regimen was really efficient in first line, and if the patient relapse after maybe 2 years or 3 years, bortezomib is still okay. So we have not a unique way to treat patients.
And you are also looking at the cytogenetic to make your decision, or you?
Yeah.
Make the...
When there is a poor cytogenetic, we often give a longer treatment. You know, when the patient has a severe disease, and if he had relapse rapidly after the previous treatment, we give a longer treatment. Whereas if it's a patient with no severe disease, maybe renal only patients with no renal insufficiency, we can give daratumumab monotherapy for 6 months and look at what happened next. And when you have a long remission with daratumumab, you can give daratumumab again, and it can be really efficient at third line treatment.
And so for you, autologous stem cell transplantation, it's really that because when you are looking at but we also a little bit that 1 year ago published our Belgium guidelines, and still say that there is some indication of high dose melphalan and autologous stem cell transplantation in AL amyloidosis, and other groups publish the same attitude. But I think that probably Dara changed things.
I think it was Gianpaolo. I heard your talk in a custom meeting, and I agree with most of things that you said. And I think the good indication and patient with IgM, because it's very, very difficult to reach a CR in patient with an IgM. and some patients with a real multiple myeloma and a mild amyloidosis, but otherwise, the presentation for the MD Anderson, I think it shows that even in patients who are refractory, it's not really a good treatment comparing to the new treatment. You know, it's only 29% of VGPR or better. It's not really good. And I think in Italy, you present only as an abstract the result of autologous stem cell transplantation for patients who did not respond to MDEX, to melphalan dexamethasone, and it was not really good.
Yes, can I add something? Because what is clear is that the survival in patients with amyloidosis clearly depends on the quality of the response, the CPR or beta CR. And if you look at so it is clear that there is a nice study from the Mayo Clinic that show that patients surviving more than 10 years, the determinant of survival is the quality of the response to frontline therapy. So if you compare the outcome of the Andromeda study with the outcome of the BEST study of stem cell transplantation, even not considering that patients undergoing stem cell transplant are highly selected, the percentage of complete responses using high-dose melphalan is inferior to that of Dara plus Cyborg. So this is clearly closing the question, in my view, that there is no reason nowadays to use high-dose melphalan with this regimen available. And I think that the rationale is rather strong. I don't know, Natalie, what you think about it.
I totally agree. I think that now we published, I don't know, maybe little bit more than 1 year or 2 years ago, and saying that probably with the arrival of Dara, things will change, that there is very few indication of high-dose melphalan, only in, as you said, in patients with low stage and in very good performance status, but now with the results of the VCD Dara, I think that it's complicated to give a treatment with even if the patient has a good performance status and no cardiac involvement or low Mayo stage clinic. There is always a risk, and I think that we have to update our guidelines, and I think that probably there will be only few indications, as Arnauld said.
If I have well understood, in the safety phase of the Andromeda trial, it was 28 patients with VCD Dara, 2 received an autologous stem cell transplantation, and the 2 patients died of the transplantation.
Yes, I heard that also.
So,
yes.
That was not a good idea, I think.
No, yes.
The only, maybe now the only real good reason to do an high-dose treatment is money.
Yeah.
Because I think it costs less than 2 years of Daratumumab, but I think it's not. Otherwise, it's not a good idea.
In Europe, so far, we can choose what is best for the patient.
Yeah.
So,
We have this change, yes. And for the treatment at the relapse, Arnauld, when will you treat your patient? You will say that there is no one answer and that it depends of the presentation at the diagnosis. We are usually retreating patient directly when there is a biologic relapse for patient with severe presentation at the diagnosis, but for some other patient, sometimes we are little bit waiting. What is your?
Yeah, for patients with a severe cardiac disease at diagnosis or other severe organ involvement, I think that if you see a relapse, an hematologic relapse, you have to treat patients. When I do some talk, I show the curve of an old lady. We treat him with Amdex 13 years ago, and she was in complete response, and she had a very severe cardiac involvement, and she was really good. Really, she really had a good evolution, and her free light chains, there were 300 at beginning. And I see a very slight increase in free light chain to 43 milligram, and it was enough to completely decompensate his heart, and it was very rapid. So this kind of patient you have to treat if you see a response. Otherwise, when there is a not severe disease, a patient with a complete renal response and no renal insufficiency, sometimes you see the free light chain going to maybe 70 milligram, and they stay for 3 or 4 years like this, and no proteinuria. So this patient, I think you can look at the free light chain, the proteinuria, and not retreat immediately. Daratumumab is a changing drug because it's not toxic. So before we try to obtain almost a VGPR, and now I think now if patient is not in CR and has not received daratumumab, it's really a question. Do you let the patient in partial remission, or do you have to give him daratumumab? And it's also for relapse. It's easier to treat a patient with daratumumab than with toxic drugs. So it's a changing thing.
And sometimes you have patients with a very good answer based on the light chain. So the differential is less than 10, and it's totally normal. There is no the ratio. I know that it's not the best biological marker, but very good and rapid answer, and no answer on your monoclonal your monoclonal protein in the electrophoresis. So are you following the answer on your light chain, the toxic chain? And so if there is no answer on your electrophoresis, you are continuing the treatment based on this answer? Or?
I think the more important is the response on the light chain. And sometimes you have a very good organ response with a remaining spike. So it depends on if you have or not an organ response, but I think really you have to follow the free light chain.
Because it's not possible to say that you are in complete response if you have still a M spike, and then
But you know, some patients are not in.
We are doing the same, yes.
And they can be well for many years. The MRD studies show that, so that patients are not in MRD negative, but they can stay 10 years in remission. So amyloidosis is not myeloma. You can have very long partial response. And if you have an organ response, it's okay.
Yes, we are doing the same, but sometimes you have to wait for your organ response, and then it's a little bit tricky.
But I think MRD, it was a nice study from Italy, showing that patient with MRD negative, patient in CR and the negative MRD, that they have a better organ response rate and a better PFS. So I think with the new drugs, we will be more exigeant, I don't know the term in English, but we will really try to obtain the best response.
Yeah, I fully agree, Arnauld, and the goal is just to improve the organ dysfunction, of course, because the clone per se is not so dangerous. So you are right, in certain patients you can achieve a good organ response even with a partial response. But if you don't see an organ response, you should go really for MRD negativity, because that is the way to induce the organ response. And in this patient, the organ response is about 90%. So practically all of them do obtain an organ response. So again, the organ response is true. Actually, it can take time to show.
Yes.
And but nevertheless, the goal, as Arnauld said, in this patient is to try to reduce the light chain as deep and as quick as possible, in any case. And if you don't achieve that, you must change quickly the therapy. For this reason, I'm also very much interested in the venetoclax option. Of course, it's only for 50% of the patient, but if you have the translocation, if you don't get a good response, can be switched to venetoclax.
What is particularly tricky is patients we have a worsening in organ disease and normal free light chain. You know, some patients, and we have a very sensitive way to check MRD with NGS on RNA in Limoges, and for some patients we find a remaining clone in the bone marrow, and probably producing a very low level of free light chain, but enough to be responsible for the organ damage. So MRD is really important.
Yes, so if we have some difficult patient, we can send to you sample for the analysis.
Yeah.
It's true that for some patients, it's very difficult to follow them because they have a very low differential in light chain, and so it's very complicated.
I think the new technique of proteomic in the serum, they will be really interesting. I don't know if you have in Italy this kind of technique. Like in the Mayo Clinic, or it's tried in France in some center. And I think in amyloidosis it would be really interesting, because when you have 20 milligram of lambda light chain, maybe there is 10 milligram of monoclonal and 10 milligram of polyclonal. So with the proteomic, I hope we will characterize this remaining monoclonal chain.
I agree. We do have the technology, and I agree also that the most important application is just to distinguish between polyclonal and monoclonal. I don't believe that it will be so good for MRD, but I believe that it will be very helpful in distinguishing between polyclonal and monoclonal and give you an indication about therapies. In that case, it may be particularly useful in amyloidosis, I believe.
Well, I think everything has been addressed. So it has been really exhaustive and very interesting debate. Thanks to all of you for your contribution for the success of this webinar.